Hello and welcome. I'm Judy Burkhardt, Executive Director of the Nursing Programs for Kaplan, and welcome to this discussion of pharmacological and parenteral therapies. This area will be 13 to 19% of the questions you see on your NCLEX exam. And we're going to be talking about blood and blood products, we're going to be talking about intravenous fluids, and we're going to be talking about medication. Let's begin. First thing we'll talk about is blood and blood products. When you talk about blood and blood products, the first thing you have to be well aware of is blood group compatibility. Remember that type O is the universal donor. They can give blood to anybody. And type AB is the universal recipient. They can receive blood from any type of other blood type. When we talk about bloods and what's given, before we talk about actually how to do it, let's talk about what is administered. You can give patients packed red blood cells, and many times this is preferable to giving patients whole blood because they need the packed cells and the oxygen carrying capacity, but they don't need the volume. Another thing that patients can be given are platelets. And again, these are given as units and usually quite quickly. Another blood component that can be used is plasma. Again, when you give plasma, it's administered with a straight line set. Another blood component that can be administered is albumin. When you give albumin, it comes with its own administration set, and again, it's usually given quite quickly. You can give prothrombin, and again, you use a straight line with that blood component, or you can give factor VIII. This is used for patients with hemophilia. So we've talked about the different components that can be given. Let's talk about actually the implementation. First of all, before you would give any blood product to anyone, you need to make sure that their blood type has been typed and cross-matched to make sure that whatever donor blood or blood components are compatible with what the patient's blood is. You will get baseline vital signs because you'll be checking vital signs frequently throughout the administration of the blood and blood products, and you need to know where to begin or what the patient's vital signs were at the beginning of the procedure. When blood or blood products are used, they are very carefully checked by nurses. And there's a certain routine that the nurses go through. They will check the physician's order. They will check the patient's identity. They will check the ID band. They check the components and the type that is given. They will actually look at the blood, and they're looking for any bubbles or any dark color or any cloudiness. And again, before the blood is given, they would question the client quite completely about any previous blood or blood products that they had received and whether or not they had any problems when they received them before. Blood and blood products are given with a 19-gauge needle for access. Again, it needs to be that large for the blood cells, the RBCs, to be able to slide through without rupture. You always start blood and blood products with normal saline. This is the most common mistake made by new graduates, as they start it with half normal saline or lactated ringers or some other type of fluid, but 0.9% sodium chloride or normal saline is the fluid of choice to start blood and blood products. When you start the blood, you will start it slowly, and that means 5 milliliters per minute during the first 15 minutes of administration, and you will stay with the patient. This isn't something you turn it on and then come back in 10 minutes and ask the patient how they're doing. You will stay for them or stay with them the first 30 minutes. Again, slowly the first 15 minutes during this time, you will be checking vital signs to see if there are any changes from the baseline vital signs that you've established. If there are no changes in vital signs and the patient has no untoward effects, then you will increase the rate that the blood is given. And usually blood or blood products, the RBCs and the whole blood is to be infused over 2 hours for each unit. And again, some of the other products are to be infused more quickly. What you will do is you will take the vital signs every hour while the infusion is in place. Every 15 minutes until it's established that things are stable, and then every hour, and then you'll continue to take them hourly for 3 hours after the transfusion is completed. What you're looking for is you want to make sure the patient doesn't experience a transfusion reaction. And there's several different types of reactions, and let's talk about those now. The first type of reaction is an allergic reaction, and this is due to a hypersensitivity to the blood. What you'll see with this is the urticaria, the pruritus, they may have a fever, and they may actually go into anaphylactic shock. What you'll do for this type of reaction is you give them supportive care. You'll give them Benadryl, which is an antihistamine. You'll give them oxygen. If they go into anaphylactic shock, you will do all the things that go along with that type of problem. The second type of problem is a hemolytic reaction, and this is caused by an incompatibility between the blood that was given the patient or the blood product and the patient's blood. The type of signs and symptoms that they will experience are pain in the lower back. They may become hypotensive, and again, you're checking the vital signs frequently. There may be an increase in pulse rate and a decrease in urine output, and they may have hematuria, which is blood in the urine. If the patients have a hemolytic reaction, again, you'll give them supportive therapy. You will start them on oxygen. You'll give them Benadryl, which is an antihistamine, and you will make sure that they maintain a patent airway. The third type of reaction is the febrile reaction, and this is the most common type of transfusion reaction that patients experience. And the cause for it is that there's antibodies in the blood or the blood product that was given the patient that reacts with the patient's blood. The type of symptoms the patients will have, they'll have fever, chills, they may have nausea, and again, they may have tachycardia, which is another reason, again, remember you're checking the vital signs very frequently. Usually you will see the febrile reaction after the patient has had multiple transfusions. The last type of transfusion reaction is the bacterial reaction, and this is because you have given the patient something that was contaminated. The type of signs and symptoms you will see are hypotension, fever, chills, and the patient may develop shock. What they will do with a bacterial reaction is they will give the patient antibiotics, they will give them IV fluids to maintain volume, they may use vasopressors to maintain the blood pressure, and they may use steroids as an anti-inflammatory. Now what you will do, okay, these are the type of reactions you may see, so what should you do if you suspect your patient is having a transfusion reaction? Well, the first thing, if you even suspect this may be happening, you don't keep the blood going or the blood product going and then check things out. You will stop the blood, you will restart the normal saline, and then you will check things out. And the first thing you will check out is to make sure that your patient has an airway, that they are actively breathing and have adequate respirations. They use Benadryl, which is an antihistamine. They may use aspirin. You will return the blood container to the blood bank. It is not something that is thrown away. And you will collect blood and urine samples to send them to the lab for analysis. And you will monitor voiding. And again, you're looking for the hematuria that may be seen with some of the blood type of reactions that we talked about. Again, the biggest thing and frequently tested on the NCLEX is if you should know the signs and symptoms of the transfusion reactions, and the most common question is what should you do? Stop the blood, restart the normal saline, and then do a thorough assessment of your patient, beginning with their airway. Okay, let's go on and talk about autologous transfusions. This is where there is a preoperative donation. The patient kind of banks blood for themselves because they know they're going to have surgery in 4 to 6 weeks. The good thing for this, again, is you don't get anyone else's problems, any viral infection or that type of thing. You know that your blood that you donate to yourself is compatible with the type of blood that you have. So it is used for patients that have a history of some type of transfusion reaction, or if patients have very rare blood types. So it is contraindicated. You cannot do this if you have an infection. You cannot do this if you have a chronic disease or cerebrovascular or cardiovascular disease. But otherwise, the autologous transfusion is a great way to make sure that if you know that you're going to have surgery and there's a good possibility that you're going to need blood or blood products after surgery, that you can do that without experiencing some of the complications that go with other people's blood or donated blood. Let's talk now about intravenous therapy. Okay, when you talk about parenteral therapy and IV fluids, let's talk first about some definition of terms, because I'm going to start throwing around these terms, and I want to make sure we're all on the same page. First of all, when we talk about tonicity, that's the concentration of substance that is dissolved in water. So the tonicity tells you how much stuff is in the fluid. Now, isotonic fluids are fluids that have the same concentration as body fluids. They are exactly the same. They have the same amount of solutes in solution. A hypertonic solution, on the other hand, the solute concentration is greater than that of body fluids. There's more stuff in it. It's more concentrated. Hypotonic solution, on the other hand, have less concentration of solutes than are found in body fluids. And there are different times and different situations where the different types of fluid are used, and we will go through that. Now, again, a couple more definitions before we start talking about the fluids themselves. Remember, when you talk about intake, intake is everything that goes into the patient, oral fluids, IV fluids, gavage feeding, any type of retained irrigations would be considered intake. Now, on the other hand, output is everything that goes out of the patient, insensible loss with perspiration, urine, diarrhea, vomiting, sweat, any type of drainage would be considered output. Okay, we've got our terms down. Now let's talk about parenteral fluids. The key thing to remember when you're talking about IVs is the main purpose of an IV is to restore fluid and electrolyte balance. And again, many times the NCLEX will ask you questions to find out, do you know that? Because if you've been in a hospital, on the floor recently, many people may think that the primary purpose of IVs is what is the real secondary purpose, and that is to give medications, to provide nutrition, or to provide blood components. But that is a secondary purpose for giving IV fluids. Again, when you're talking about IV fluids, you need to remember we talked about the tonicity, which is the amount of solute that is in the solution compared to body fluids. Isotonic are the same concentration as body fluids, and these are normal saline, and remember normal saline is 0.9% sodium chloride. Lactated ringers is another type of isotonic fluid. 5% dextrose in water is considered an isotonic fluid. When you talk about hypotonic fluids, you're half normal saline. And again, it's the 0.45 sodium chloride, or half normal saline is a hypotonic fluid, meaning the tonicity is less than body fluids. And your hypertonic fluids, again, have a tonicity greater than body fluids. These are your D10 in water, your D15 in water, 3% sodium chloride, and sodium bicarbonate 5%. Again, these are hypertonic solutions.